Sympathomimetics. Sympathomimetics are drugs that usually mimic the response that would be expected from increasing sympathetic outflow. They are also called adrenergic drugs because they act like our endogenous catecholamines, dopamine, norepinephrine, and epinephrine, by either directly or indirectly stimulating alpha, beta, and dopamine receptors. Now, all of these drugs listed are super high yield. So in order to make this easier, I'm going to categorize them based on which receptor they predominantly stimulate. Let's start out with those that stimulate our beta receptors. Do you remember from our lecture on G proteins, which G protein is coupled to all beta receptors? That's right, GS. And what intracellular process occurs after stimulating our beta receptors? Again, this is a super high yield pathway that you must know. The G protein coupled subunit, GS, leads to the activation of adenylyl cyclase, which converts ATP into cyclic AMP. Cyclic AMP then goes on to activate protein kinase A. Increased activity of protein kinase A in the heart leads to increased intracellular calcium, which we know leads to increased contractility and heart rate. But an increase in protein kinase A activity within smooth muscle is a different story. pKa phosphorylates myosin light chain kinase, preventing it from working. Inhibition of myosin light chain kinase means we cannot phosphorylate myosin. Do you remember from the physiology section on muscle contraction what would happen if myosin was not phosphorylated? Without a phosphate, myosin cannot return to a cocked position and cannot participate in any more power strokes or contractions. So the main point is that we get smooth muscle relaxation. We actually use this mechanism to our advantage when giving beta-2 agonist drugs like albuterol and salmeterol to asthma and COPD patients. We want bronchial smooth muscle relaxation in order to open these patients' airways. Be careful though, because if you give someone too much albuterol, you can also stimulate beta-1 receptors on the heart, which results in tachycardia. Albuterol is a short-acting beta-2 agonist, while salmeterol is a long-acting beta-2 agonist. This will be important when you're actually treating asthma patients. Dobutamine favors beta-1 receptors, and therefore its site of action will be on the heart. This strong beta-1 activity makes dobutamine a useful inotropic agent, which means it increases the strength of muscle contractions. Again, by what mechanism does dobutamine increase inotropy? By increasing intracellular calcium within cardiac myocytes, increases contractility. This is why dobutamine can be useful in treating patients with heart failure, a problem with pumping blood out of the heart. This is also the reason why this agent is used in cardiac stress testing. The increase in contractility leads to an increase in myocardial oxygen demand, and by increasing the oxygen demand of the cardiac muscle, it can help you identify areas that have decreased blood flow and cannot increase oxygen supply when stressed. So I'm going to skip epinephrine and isoproterenol and come back to compare them in a bit. Mirabegron, by acting on beta-3 receptors in the bladder, can be helpful in the treatment of an overactive bladder. Remember, contraction of the detrusor will cause urine to be pushed out, while relaxation will cause it to be retained. And what other drugs did we mention in our muscarinic antagonist lecture that can also help with an overactive bladder? That's right, oxybutynin, sulfonacin, and tolterodine, which work by antagonizing M3 receptors. Now let's discuss epinephrine and isoproterenol. Epinephrine stimulates all beta and alpha receptors, but it is famous for being more potent on beta receptors. Okay, so what does this mean to us? Let's visualize this using the image from your book that compares blood pressure, heart rate, and peripheral resistance. Now, what receptors can be found on our heart? We find M2 receptors that, when stimulated, cause a decrease in heart rate, and beta 1 receptors, when stimulated, cause an increase in heart rate. So when epinephrine stimulates beta 1 receptors in the heart, there is an increase in heart rate. And what receptors can be found on the smooth muscle of our blood vessels? We find alpha 1 and beta 2 receptors that actually oppose one another. Stimulation of alpha 1 receptors cause vasoconstriction, while stimulation of beta 2 receptors cause vasodilation. Epinephrine can stimulate both alpha and beta receptors, but as we mentioned, it stimulates beta receptors more, causing vasodilation and an overall drop in peripheral resistance. The beta 1 effect on the heart leads to an increase in systolic blood pressure, but the beta 2 effect leads to a drop in diastolic blood pressure. When systolic and diastolic move in opposite directions, this is an increase in pulse pressure. And what is epinephrine classically used for? To treat anaphylaxis. Now let's move on to our pure beta agonist, isoproterenol. Isoproterenol stimulates beta 1 and beta 2 receptors and loves them both equally. Let's check out these fancy diagrams again. In the heart, isoproterenol will activate our beta 1 receptors, causing an increase in heart rate. Now pay close attention to this high yield point. This is how you are going to be able to differentiate between epinephrine and isoproterenol on your exam. Isoproterenol has only a beta 2 effect on blood vessels, compared to epinephrine that has both alpha and beta. Therefore, isoproterenol's unopposed beta 2 agonist activity drops the peripheral resistance significantly more than epinephrine's. As a result of the strong beta 2 mediated vasodilation, what baroreceptor reflex would we expect to see? This strong vasodilation makes our body think we have less blood in our system and triggers a reflex to increase heart rate and cardiac output in order to supply our body with blood. This is called reflex tachycardia. The overall effect of a net drop in blood pressure, in combination with a big jump in heart rate, makes this drug dangerous and therefore not very useful. In fact, it hasn't even been used since the 1990s. Now let's move on to our alpha agonists. There are two alpha receptors, alpha 1 and alpha 2. Now, do you remember which G proteins are coupled to our alpha 1 and alpha 2 receptors? Alpha 1 is coupled to GQ and alpha 2 is coupled to GI. Remember from our cholinomimetics lecture, the GQ pathway activates phospholipase C, which goes on to make diacylglycerol and an acetyl triphosphate. IP3 triggers the release of calcium from the sarcoplasmic reticulum. This increase in intracellular calcium leads to contraction of smooth muscle. Now, alpha 1 receptors are mainly located on smooth muscle. For example, the smooth muscle cells within our blood vessels, pupillary dilator of the eye, intestines, and bladder sphincters. Therefore, stimulation of these receptors will result in vasoconstriction, mydriasis, decreased digestion, and urinary retention. Remember, when you are running from a bear and your body increases sympathetic outflow, you definitely want to be able to see, and there's no time to digest your food and take a leak. So vasoconstriction helps shunt blood away from these organs during fight or flight. So our first drug on the page is metodrine, which is a selective alpha 1 receptor agonist. It is given to patients that have autonomic insufficiency, aka patients that have damaged neurons and have trouble regulating blood pressure in response to changes in body position. For example, when going from lying down to standing up, and we call this orthostatic hypotension. Phenylephrine was designed to be a very weak alpha-1 agonist. And the reason this drug is only useful if given as eye drops or nasal spray, which causes either mydriasis or eliminates nasal congestion. Okay, let's go ahead and discuss probably the most high-yield drug on this page, norepinephrine. You will hear the trade name of this drug, Levofed, mentioned daily on rounds in the ICU. It is a fantastic alpha-1 agonist. So, when you hear norepinephrine, just think alpha-1 agonist. The agonist activity on alpha-2 and beta-1 receptors is super weak in comparison. This drug is a must-know. It is frequently used to increase blood pressure in very sick patients that cannot regulate blood pressure on their own. And it is also used in the treatment of septic shock. Can you remember from your cardio and micro chapters what happens to the systemic vascular resistance, the SVR, in a patient with septic shock? That's right, the patient's SVR would be very low. Remember, in sepsis, the overwhelming release of cytokines causes severe hypotension, aka our blood vessels become super leaky. Therefore, giving an alpha-1 agonist like norepinephrine will help in increasing vascular resistance and blood pressure. Here again is a diagram from your book. Checking out the peripheral resistance, norepinephrine does not stimulate beta-2 receptors at all, and therefore the unopposed alpha-1 mediated vasoconstriction causes a dramatic increase in peripheral resistance. This is the complete opposite of isoproterenol that we learned had unopposed beta-2 mediated vasodilation on blood vessels. Now, norepinephrine stimulates beta-1 receptors with similar potency as epinephrine, which leads to an increase in systolic pressure. Why does the heart rate actually go down if norepinephrine is stimulating beta-1 receptors in the heart? Now, the potent stimulation of alpha-1 receptors and intense increase in peripheral resistance freaks out our baroreceptors. The baroreceptors say, wow, the pressure is way too high. We need to decrease the sympathetic activity on the heart. And this leads to a reflex bradycardia, or a decreased heart rate. This is why this drug is great for sick hypotensive patients. We increase mean arterial pressure by vasoconstriction, but the reflex bradycardia helps prevent an excessive increase in myocardial oxygen demand by decreasing sympathetic activity on the heart and neutralizing the effect of cardiac output. So when considering how to increase delivery of blood to organs in a hypotensive patient, we usually like norepinephrine because it has minimal stress on the heart. Let's move on to our final group of direct agonists. Dopamine agonists. The dopamine receptor D1 is found in the periphery, while D2 receptors are found in the brain. The two drugs we need to discuss are dopamine and phenyldopamin, which do not cross the blood-brain barrier. So we will focus on their effects on D1 receptors found on vascular smooth muscle cells. What G protein is the D1 receptor coupled to? That's right, GS, or G-stimulatory. And what is the result of activating this intracellular pathway? Protein kinase A will phosphorylate myosin light chain kinase and cause smooth muscle relaxation. Both of these drugs are useful in stimulating D1 receptors in the peripheral, coronary, renal, and splanchnic vascular beds to cause widespread vasodilation to decrease blood pressure. The use of dopamine is dose-dependent. At low doses, it stimulates D1 receptors to cause a drop in blood pressure. At medium doses, it stimulates beta-1 receptors to increase calcium in the heart and therefore increase heart rate and contractility. And at high doses, dopamine stimulates alpha-1 receptors, causing vasoconstriction. Phenyldopamin, on the other hand, is often used for hypertensive emergency because we want diffuse vasodilation. Keep in mind the stimulation of D1 receptors within the kidney also inhibits the sodium proton exchanger and therefore prevents sodium reuptake. This leads to natriuresis, which is the loss of sodium in the urine. Moving on to our indirect sympathomimetics, we use the term indirect because instead of directly stimulating our sympathetic receptors, these drugs increase the amount of catecholamines within the synaptic cleft by either causing their release or inhibiting their reuptake. Amphetamine and ephedrine are very similar in structure to catecholamines and therefore can displace them from storage places within the presynaptic terminal. This causes an increase in the release of catecholamines like norepinephrine and dopamine. The release of norepinephrine is responsible for the stimulatory effects, and the dopamine is responsible for making you feel awesome and addicted. Amphetamine has an extra mechanism of action that it shares with cocaine and TCAs. These drugs can inhibit the monoamine reuptake transporters at the presynaptic membrane. This includes all monoamines, including norepinephrine, serotonin, and dopamine. As mentioned, cocaine is a reuptake inhibitor. It also has local anesthetic effect, which is due to its sodium channel blockade. But you also need to know that it is infamous for causing intense vasoconstriction due to its alpha-1 agonism. Therefore, be on the lookout on your exam for patients with necrosis or perforations of their nasal septum. These are telltale signs of cocaine-induced vasculitis. One more high-yield point. Never give a cocaine user a beta blocker, specifically a non-selective one. Why? A non-selective beta blocker will block both beta-1 and beta-2 receptors. Beta-2 receptors mediate vasodilation. Therefore, a cocaine user using a non-selective beta blocker causes unopposed alpha-1 mediated vasoconstriction, leading to extreme hypertension.